Describe the biochemical basis of phenylketonuria and explain the rationale behind the dietary management of the disorder. Answer. Phenylketonuria is an autosomal recessive metabolic disorder caused by mutations in the PAH gene leading to deficiency of the enzyme phenylalanine hydroxylase (PAH). PAH converts phenylalanine to tyrosine in the presence of the cofactor tetrahydrobiopterin (BH). Without functional PAH, phenylalanine accumulates in the blood and tissues, becoming toxic to the developing brain and causing intellectual disability if untreated. Dietary management rationale. A low phenylalanine diet reduces toxic accumulation. Patients must avoid high-protein foods and consume specialized medical formulas with limited phenylalanine and sufficient tyrosine to meet nutritional needs. Early and consistent dietary management is essential to prevent irreversible neurological damage. Guidelines. Newborn screening programs identify PKU early, enabling timely intervention. Management is guided by regular monitoring of phenylalanine levels according to guidelines set by the American College of Medical Genetics and Genomics, Inc. Dr. Amanda has a patient, 6-month-old Liam, who has elevated plasma branched-chain amino acids and ketones. Liam was brought in with lethargy and feeding difficulties. Further metabolic testing confirmed maple syrup urine disease (MSUD). What immediate steps should Dr. Amanda take, and what long-term management strategies should be implemented? Answer. Immediate steps. Acute metabolic crisis management. Administer intravenous fluids with high dextrose concentration to reduce catabolism. Introduce insulin if necessary to promote anabolic pathways. Monitor and correct acid-base imbalances, hyperammonemia, and electrolyte disturbances. Dietary intervention. Remove all protein intake temporarily and then reintroduce carefully measured protein to meet minimal needs. Use specialized metabolic formulas without branched-chain amino acids because leucine, isoleucine, and valine. Long-term management. Lifelong dietary restriction of BCA as with regular blood level monitoring. Emergency protocols for managing infections or stress which can precipitate metabolic decompensation. Consider liver transplantation in severe cases for metabolic stability. Explain the utility of tandem mass spectrometry (MSMS) in the diagnosis of inherited metabolic disorders. Answer. Tandem mass spectrometry (MSMS) is a highly sensitive and specific diagnostic tool used in newborn screening and metabolic disorder diagnosis. Utility. Simultaneous analysis. Detects multiple metabolites including amino acids, organic acids, and acylcarnitines from a single sample. Screening capability. Identifies biochemical markers for disorders like PKU, MSUD, and fatty acid oxidation disorders. Quantitative analysis. Measures metabolite levels precisely, aiding in both diagnosis and monitoring therapy effectiveness. Example, in fatty acid oxidation disorders, abnormal acylcarnitine profiles indicate enzyme deficiencies. Guidelines. ACMG recommends MSMS for expanded newborn screening programs due to its efficiency and accuracy. Mrs. Davis is pregnant and has a family history of Duchenne muscular dystrophy (DMD), an X-linked recessive condition. She seeks advice regarding the genetic risks for her unborn child. What steps should her genetic counselor take, and what ethical considerations must be addressed? Answer. Steps. Obtain a detailed family history to confirm inheritance pattern and identify potential carriers. Offer carrier testing to Mrs. Davis for mutations in the DMD gene. If she is a carrier, recommend prenatal diagnostic testing e.g. chorionic villus sampling or amniocentesis or non-invasive prenatal testing (NIPT) to assess the fetus's genetic status. Ethical considerations. Autonomy. Ensure Mrs. Davis has all the information needed to make an informed decision. Non-directiveness. Avoid influencing her choice regarding continuation or termination of pregnancy. Confidentiality. Protect the privacy of genetic information. Guidelines. Genetic counseling practices must adhere to the National Society of Genetic Counselors (SADC) Code of Ethics and recommendations on prenatal testing. Discuss the role of mitochondrial inheritance in genetic disorders and provide an example. Answer. Mitochondrial inheritance refers to the transmission of genetic material encoded in the mitochondria, which are the energy-producing organelles within cells. Unlike nuclear DNA, which is inherited from both parents, mitochondrial DNA (mTNA) is inherited exclusively through the maternal line. This is because mitochondria are passed from mother to offspring via the egg cell, while sperm cells contribute little to no mitochondria. Mitochondrial inheritance is significant because mutations in mTNA can lead to disorders that primarily affect tissues with high energy demands, such as the brain, heart, muscles, and eyes. These disorders are often present in adulthood and may involve multisystemic symptoms, including vision loss, muscle weakness, and neurological impairments. Example: Leber's hereditary optic neuropathy (LON) is a common mitochondrial disorder. It is caused by mutations in mTNA that affect the respiratory chain complexes involved in energy production, particularly in retinal ganglion cells. This leads to progressive vision loss, typically in young adults due to optic nerve degeneration. Guidelines: Clinical diagnosis of mitochondrial disorders is often confirmed by sequencing mitochondrial genes. ACMG guidelines emphasize a comprehensive family history and multi-generational maternal inheritance patterns to identify potential mitochondrial disorders. Explain the significance of clinical exome sequencing (CES) in diagnosing rare genetic disorders. Answer: Clinical exome sequencing (CES) is a next-generation sequencing technique that targets the exon's protein-coding regions of the genome, which comprise only about 1–2% of the total DNA but contain approximately 85% of known disease-causing mutations. CES is highly useful for diagnosing rare genetic disorders, particularly in cases where the patient's clinical presentation does not fit into a well-defined syndrome or when other diagnostic methods have failed to identify the cause of symptoms. CES allows for the detection of single nucleotide variations, insertions, deletions, and copy number variations within the exons. This technique is increasingly used for patients with undiagnosed genetic conditions or complex phenotypes, as it provides a broad and detailed assessment of all coding regions. Significant benefits of CES include high diagnostic yield in patients with clinical features suggesting a genetic disorder, but with an elusive molecular diagnosis. Cost-effectiveness compared to whole genome sequencing, as it focuses on the exome and does not require the sequencing of non-coding regions. Increased accuracy and ability to detect mutations in genes that are associated with rare, complex, or poorly understood disorders. However, CES may not capture non-coding mutations, structural variations, or epigenetic changes, which may limit its scope. ACMG guidelines advocate CES for monogenic disorders and cases with genetic heterogeneity when a clear diagnosis is not reached through other diagnostic avenues. Mr. Patel, age 35, is found to have a novel variant of uncertain significance VUS in the BRCA gene during cancer predisposition testing. He is concerned about the implications for his family. How should this be addressed in genetic counseling? Answer: a variant of uncertain significance (VUS) refers to a genetic alteration that has been identified but does not yet have enough clinical evidence to be classified as either benign or pathogenic. In Mr. Patel's case, the VUS in the BRCA gene does not currently indicate whether it increases the risk of breast or ovarian cancer, making the interpretation complex. The genetic counselor should follow these steps. Explain the nature of VUS. Educate Mr. Patel that a VUS means there is insufficient evidence to conclude whether the variant causes disease. This could be due to a lack of studies linking the variant to cancer or contradictory data regarding its pathogenicity. Interpretation and uncertainty. Reassure Mr. Patel that, as of now, no clinical action is warranted. Family implications. Cis-area mutations are associated with autosomal dominant inheritance. Mr. Patel's family members, particularly female relatives, could be at risk for related cancers. Actionable steps. It's important to inform Mr. Patel that, if new information arises and the VUS is reclassified as a pathogenic mutation, he and his family may need to consider preventive measures, e.g., increased cancer screening, prophylactic surgeries, or chemoprevention. Compare autosomal dominant and autosomal recessive inheritance patterns. Provide clinical examples. Answer: autosomal dominant and autosomal recessive inheritance patterns differ in how traits are passed from parent to offspring. Autosomal dominant. A single copy of a mutated gene from either parent is sufficient to express the disorder. Affected individuals have a 50% chance of passing the mutation to each child. Males and females are equally likely to be affected. Examples: Marfan syndrome, caused by mutations in the FBN gene. This condition affects connective tissues, leading to cardiovascular, skeletal, and ocular abnormalities. Huntington's disease, a neurodegenerative disorder caused by an expansion of CAG repeats in the HTT gene. Symptoms generally appear in mid-adulthood, and it is characterized by movement problems, cognitive decline, and psychiatric issues. Autosomal recessive. 2 copies of the mutated gene, one from each parent, are required to express the disorder. Affected individuals typically have 2 carrier parents who do not show symptoms. Carriers heterozygotes are asymptomatic but can pass the mutation to their offspring. Examples: cystic fibrosis, caused by mutations in the CF. TR gene. It results in thick mucus accumulation in the lungs and digestive system, leading to respiratory issues and poor growth. Sickle cell disease, caused by a mutation in the HBB gene. It leads to abnormal hemoglobin and deformed red blood cells, resulting in anemia and vaso-occlusive crises. Guidelines, genetic testing and family history analysis are critical for accurate diagnosis and understanding inheritance patterns. ACMG guidelines recommend genetic counseling for individuals and families affected by these disorders to discuss risks, prevention, and reproductive options. Discuss ethical challenges associated with incidental findings during genomic testing. Answer: incidental findings are unexpected results that arise during genetic testing, which are unrelated to the primary clinical indication for the test. These findings can have significant ethical implications, particularly when they relate to conditions that the patient was not originally tested for but could affect their health or the health of their family members. Ethical challenges include disclosure versus non-disclosure. Should clinicians disclose these findings even if they were not directly related to the patient's condition? The primary ethical principle is autonomy. Patients should have the right to decide whether they want to know about incidental findings. However, withholding relevant health information may not align with the principle of beneficence, especially when the finding is clinically actionable, e.g., a mutation associated with a treatable condition. Patient preferences. Before testing, patients should be informed of the potential for incidental findings and asked to indicate their preferences. Some patients may choose to receive all results, while others may opt to exclude certain types of findings, such as those related to predispositions for non-critical conditions. Family implications. Incidental findings may also have implications for family members who might be at risk for the same genetic condition. Genetic counselors should discuss the familial nature of genetic information and the potential need for relatives to undergo testing. Guidelines. The Inc.'s policy on incidental findings emphasizes that clinicians should seek informed consent before performing genomic testing and should have a clear plan for addressing any incidental findings. Describe the role of enzyme replacement therapy in treating lysosomal storage disorders. Answer: enzyme replacement therapy is a treatment strategy used to address lysosomal storage disorders, LSDs, which are caused by deficiencies in specific lysosomal enzymes that lead to the accumulation of undigested substrates within lysosomes. RT involves administering recombinant versions of the deficient enzyme, which are designed to be delivered to the patient's cells to reduce substrate buildup and alleviate symptoms. Role of RT in LSD treatment. Gaucher disease, caused by a deficiency of glucose ribosydase, leading to the accumulation of glucose riboside in macrophages. RT with imiglucerase serozyme helps to reduce organ enlargement, pain, and bone issues in affected individuals. Pompe disease, caused by a deficiency in acid alpha-glucosidase. RT with alglucosidase alpha myozyme helps to improve muscle function and reduce heart issues associated with this disorder. Effectiveness and challenges. RT is effective in treating systemic manifestations such as organ enlargement, bone abnormalities, and neurological symptoms, but it does not cure the disease or reverse damage already done to tissues. Some limitations include the need for lifelong therapy, potential immune reactions to the recombinant enzymes, and the high cost of treatment. Guidelines. The ACMG and NIH emphasized the importance of early diagnosis and initiation of RT to improve outcomes in lysosomal storage disorders. However, eligibility for RT is determined by the severity of the condition and patient-specific factors. What is the role of the CYP gene in drug metabolism, and how can genetic variations in this gene affect patient outcomes? Answer: the CYP gene encodes an enzyme that is a major player in the metabolism of various drugs, including antidepressants, opioids, and beta blockers. Genetic polymorphisms in CYP result in variable enzyme activity, categorized into 4 metabolizer phenotypes. Poor metabolizers, PMS, little or no enzyme activity leading to reduced drug clearance and potential toxicity. Intermediate metabolizers, IMS, reduced enzyme activity causing slow drug metabolism. Extensive metabolizers, EMS, normal enzyme activity metabolizing drugs efficiently. Ultra-rapid metabolizers, UMS, increased enzyme activity leading to rapid drug clearance and potential therapeutic failure. For For example, codeine is metabolized to morphine by CYP. UMS may experience toxic effects due to rapid morphine production, while PMS may have inadequate pain relief. Clinical guidelines, such as those from CPIC Clinical Pharmacogenetics Implementation Consortium, recommend adjusting drug doses based on the patient's CYP genotype. Sarah, a 45-year-old patient, is prescribed clopidogrel following a stent placement for coronary artery disease. Genetic testing reveals she is a poor metabolizer of CYP. Question: what clinical actions should the physician take and why? Answer: clopidogrel is a prodrug that requires activation by the CYP enzyme. Poor metabolizers PMS of CYP fail to convert clopidogrel into its active form, resulting in inadequate platelet inhibition and an increased risk of thrombotic events. Recommended actions: switch to an alternative antiplatelet agent, such as prasugrel or ticagrelor, which does not depend on CYP for activation. Follow guidelines from organizations such as CPIC or FDA, which label clopidogrel with a pharmacogenomics warning. Monitor for signs of thrombotic complications if switching medications is not possible. Explanation: this approach mitigates the risk of adverse cardiovascular events by ensuring effective antiplatelet therapy. Describe the diagnostic utility of urine organic acid analysis in diagnosing inborn errors of metabolism such as maple syrup urine disease (MSUD). Answer: urine organic acid analysis is a cornerstone in diagnosing inborn errors of metabolism. It identifies abnormal metabolites, such as branched-chain ketosids, which accumulate in conditions like MSUD due to defective branched-chain ketoside dehydrogenase. Key diagnostic features of MSUD: elevated levels of leucine, isoleucine, and valine branched-chain amino acids in plasma. Urinary excretion of branched-chain ketosids detected via gas chromatography mass spectrometry (GMS). Early diagnosis is critical for initiating dietary management, low protein intake, and preventing neurotoxicity. Case study: a newborn presents with lethargy, vomiting, and a maple syrup-like odor in the urine. Initial labs show elevated plasma branched-chain amino acids. Question: what is the immediate treatment approach and why? Answer: immediate management. Administer high-dose glucose infusion to reduce catabolism and amino acid accumulation. Begin hemodialysis or exchange transfusion if plasma leucine levels are critically high, 1000 mmol. Initiate a specialized low-protein diet with branched-chain amino acid restriction. Rationale: the maple syrup odor and laboratory findings suggest MSUD, a life-threatening disorder that requires urgent metabolic stabilization to prevent irreversible neurologic damage. Dialysis reduces toxic metabolites rapidly, and dietary interventions maintain metabolic control. Guidelines: the American College of Medical Genetics and Genomics recommends newborn screening and prompt treatment for MSUD to prevent complications. What is the genetic basis and clinical management of Gaucher disease, a lipid metabolism disorder? Answer: genetic basis. Gaucher disease is caused by mutations in the GBA gene leading to deficiency of the enzyme glucocerebrosidase. This results in the accumulation of glucocerebroside in macrophages, forming Gaucher cells. Clinical features: type 1, non-neuropathic, splenomegaly, hepatomegaly, bone pain, and anemia. Type 2, 3, neuropathic, severe neurological symptoms. Management: enzyme replacement therapy, intravenous administration of recombinant glucocerebrosidase, imiglucerase, substrate reduction therapy (SRT), oral agents like oligostat that inhibit glucocerebroside production. Monitor and treat complications such as osteoporosis and anemia. Guidelines: treatment decisions should follow recommendations from organizations like ACMG and consider genotype-phenotype correlations. Explain the role of VCORC gene variants in warfarin metabolism and how genetic testing can influence warfarin dosing. Answer: VCORC, vitamin K epoxide reductase complex subunit 1, is a key enzyme involved in the production of clotting factors. Warfarin, an anticoagulant, inhibits VCORC, thereby reducing clotting factor synthesis. Variants in VCORC affect an individual's sensitivity to warfarin. Key variants and dosing impact: low-function VCORC alleles e.g. 1639 grams result in increased sensitivity to warfarin, requiring lower doses. High-function VCORC alleles e.g. 1639 grams result in warfarin resistance, requiring higher doses. Clinical testing and guidelines: genetic testing for VCORC and SIC, which affects warfarin metabolism, can guide individualized dosing. For example, the Clinical Pharmacogenetics Implementation Consortium (CPIC) and FDA recommend using these genetic tests to adjust initial warfarin doses and avoid adverse effects such as bleeding or thrombosis. Case study: Mr. Davis, a 58-year-old man with atrial fibrillation, is prescribed warfarin. His genetic test results show he has a SIC33 genotype and the VIA-CORC 1639 grams of polymorphism. Question: how should his warfarin dose be adjusted based on his genetic results? Answer: warfarin dosing adjustment. The SIC3 genotype is associated with a reduced ability to metabolize warfarin, meaning Mr. Davis is likely to need a low dose to avoid bleeding complications. The VIA-CORC 1639 grams of polymorphism indicates increased sensitivity to warfarin, further supporting the need for a reduced dose. Clinical action: Mr. Davis should be started on a lower initial dose of warfarin, typically around 2.550% lower than the standard dose. Close monitoring of his INR, international normalized ratio, should be performed to ensure that it remains within the therapeutic range, typically 2.3 for atrial fibrillation. Adjustment of the dose should be based on ongoing INR levels and clinical response per CPIC guidelines. Explanation: genetic testing allows for a personalized approach to anticoagulation therapy, minimizing the risk of both bleeding and thromboembolic events. Discuss the role of enzyme-based therapies in the treatment of lysosomal storage diseases, specifically for Gaucher disease. Answer: lysosomal storage diseases (LSD) are caused by enzyme deficiencies that lead to the accumulation of substrates within lysosomes. In Gaucher disease, the deficiency of glucose rubrosidase leads to the accumulation of glucose rubrosid in macrophages, causing symptoms such as hepatosplenomegaly and bone pain. Enzyme replacement therapy. Imiglucerase, a recombinant form of glucose rubrosidase, is the standard RT for type 1 Gaucher disease, non-neuropathic. RT is administered intravenously and helps reduce the accumulation of glucose rubrosid, improving organ function and reducing symptoms. Substrate reduction therapy (SRT). Aliglustat is an oral agent used for patients with type 1 Gaucher disease who are not suitable for RT. Works by inhibiting glucose rubrosid synthesis, reducing the substrate buildup. Guidelines: according to a CMG and FDA guidelines, treatment decisions for Gaucher disease should be based on genotype, phenotype, and the patient's response to therapy. Case study: Emily, a 30-year-old woman with a family history of Gaucher disease, is diagnosed with type 1 Gaucher disease after genetic testing reveals mutations in the GBA gene. Question: what therapeutic options are available for Emily, and how should her treatment plan be personalized based on her diagnosis? Answer: therapeutic options. Enzyme replacement therapy. Emily should be considered for imiglucerase, which is the first-line therapy for type 1 Gaucher disease. RT would help reduce the accumulation of glucose rubrosid in her organs, particularly her spleen and liver. Substrate reduction therapy (SRT). If Emily is unable to tolerate RT or prefers oral medication, aliglustat may be considered. This drug is used to reduce glucose rubrosid production by inhibiting glucosylceramide synthase. Personalization of treatment. Treatment should be tailored based on Emily's symptom severity, liver and spleen size, and bone involvement. Genetic testing, including a detailed analysis of her GBA mutations, can guide the decision to start a RT or SRT with consideration of potential side effects and treatment adherence. Regular monitoring should include tracking her hemoglobin levels, liver function, and bone health to assess the effectiveness of the chosen therapy. What are the genetic and clinical features of galactosemia, and how is it managed in the neonatal period? Answer: galactosemia is an autosomal recessive disorder caused by a deficiency in one of three enzymes involved in galactose metabolism: galactose 1-phosphate uridyl transferase, galactokinase GALK, or uridine diphosphate galactose 4-epimerase GAL. The most common form is caused by GALT deficiency. Genetic basis: GALT mutations lead to the accumulation of galactose 1-phosphate, causing damage to the liver, kidneys, and brain. GALK deficiency results in cataracts, and GALE deficiency can cause milder symptoms. Clinical features: neonatal galactosemia presents with jaundice, failure to thrive, and vomiting shortly after birth. If untreated, it leads to liver failure, cataracts, and developmental delay. Management: the cornerstone of treatment is the immediate elimination of galactose from the diet, typically through a galactose-free formula. Lifelong dietary restrictions are necessary, though some complications, such as cognitive deficits and ovarian failure, may persist despite early treatment. Guidelines: newborn screening for galactosemia is recommended in many countries, allowing for early diagnosis and intervention. Treatment protocols are well established, with guidelines from ACMG and other health organizations emphasizing prompt initiation of dietary management to avoid severe complications. What is the primary purpose of genome-wide association studies, GWAS, and how are statistical associations interpreted in terms of causality? Answer: the primary purpose of GWAS is to identify genetic variants associated with specific traits or diseases across the genome. GWAS analyzes common single nucleotide polymorphisms (SNPs) in large populations to detect statistical associations between genetic loci and phenotypes. Key points to understand: statistical causality. Association indicates that the genetic variant and the phenotype could occur more frequently than expected by chance. However, it does not prove that the variant causes the trait. Linkage disequilibrium (LD). Many SNPs a region may show association due to LD, but only one or a subset may be causal. Functional studies are required to confirm causality. P-value thresholds. GWAS typically uses a stringent threshold to account for multiple testing, relevant guidelines, and concepts. Results should be interpreted with caution, especially in the presence of confounders or population stratification. Ethical implications must be considered when applying GWAS findings to clinical settings. Explain the role of the UCSC Genome Browser in genomic data interpretation. Provide an example of how it is used in clinical genetics. Answer: the UCSC Genome Browser is a graphical interface for exploring genomic data, including gene structure, regulatory elements, variants, and conservation. It integrates multiple data sources for comprehensive analysis. Applications in clinical genetics. Variant annotation identifies the location of a variant within coding, non-coding, or regulatory regions. Functional prediction links to databases like ENCODE to assess regulatory elements or transcription factor binding sites. Case study: a variant in BREA is identified in a patient's exome. Using the UCSC Genome Browser, the variant's conservation across species is checked to assess potential pathogenicity. Overlaying with ENCODE, data may show the variant disrupts a known enhancer. Key guidelines: use tools like the UCSC Genome Browser in conjunction with guidelines for variant classification. Dr. Karen is reviewing the case of a 45-year-old patient with familial hypercholesterolemia. Exome sequencing revealed a novel variant in the LDLR gene. The variant is located in a conserved exon and changes a polar amino acid to a nonpolar one. Functional studies are pending. How should Dr. Karen classify this variant according to ACMG guidelines, and what additional steps should she take to refine the classification? Answer: using ACMG guidelines, the variant would likely be classified as variant of uncertain significance, thus initially given the absence of functional evidence or population data. Steps to refine classification: population databases. Check databases like NOMAD for allele frequency. If the variant is rare or absent, it strengthens its potential pathogenicity. Functional evidence: pending studies should assess the impact of the amino acid change on protein function. Segregation analysis: determine whether the variant segregates with the phenotype in the family. Conservation and computational predictions: the conserved nature of the site and in silico tools like SIFT or polyphon may support pathogenicity. Relevant guidelines: again, variant classification framework outlines 5 classes. Pathogenic, likely pathogenic, VUS, likely benign, benign. Describe the clinical utility of liquid biopsies in cancer management. Answer: liquid biopsies involve analyzing circulating tumor DNA or circulating tumor cell ECS in blood. Clinical utility: early detection. eDNA can detect minimal residual disease earlier than imaging techniques. Monitoring treatment response. Quantifying eDNA provides a non-invasive measure of tumor burden. Resistance mechanisms: identifies secondary mutations that confer drug resistance. GTM mutation in GFR in lung cancer. Key guidelines: ensure liquid biopsy findings are validated with standard tissue biopsies when possible. Regulatory standards such as CLIA certification are necessary for clinical labs conducting liquid biopsies. Mr. Smith, a 38-year-old man, presents with early-onset colorectal cancer. Family history reveals multiple relatives with similar diagnoses. Genetic testing identifies a pathogenic variant in the MHDN. What syndrome does this likely indicate, and what are the recommended clinical interventions for Mr. Smith and his family? Answer: the findings suggest Lynch syndrome, hereditary non-polyposis colorectal cancer, caused by mutations in mismatch repair, IMSUTA, genes like MH. Recommended interventions: surveillance for Mr. Smith, annual colonoscopy starting immediately, endometrial cancer screening for female relatives, family testing, cascade testing to identify at-risk relatives. Preventative measures: consider prophylactic surgeries based on organ-specific risk. E.g., colectomy. Treatment implications: tumors with MMR deficiency are candidates for immune checkpoint inhibitors. Relevant guidelines. NCCN guidelines for Lynch syndrome management. Explain how the GAMP guidelines are applied to classify genetic variants in clinical practice. What factors should be considered in determining whether a variant is pathogenic or benign? Answer. The GAMP guidelines provide a structured framework for classifying genetic variants based on multiple criteria, including functional evidence, segregation in families, population data, and computational predictions. Factors to consider in classification: population frequency. Variants found in a large percentage of the general population may be benign, e.g., variants found in nomad at high frequencies. Computational evidence. Tools like SIFT and Polyphon predict whether a variant affects protein function. Pathogenic variants typically disrupt protein structure or function. Segregation analysis. A variant segregation with disease in families, if available, strengthens the evidence for pathogenicity. Functional studies. Experimental evidence demonstrating a deleterious effect on protein function, such as loss of function assays, supports pathogenicity. Literature and database evidence. Published data or databases like ClinVar and HGMD that report pathogenic associations with a specific disease. How can pharmacogenomics be applied in clinical practice, and what are the challenges associated with its integration into patient care? Answer. Pharmacogenomics involves the study of genetic variations that influence drug metabolism, efficacy, and toxicity. This field helps tailor drug therapies to individual genetic profiles, optimizing therapeutic outcomes and minimizing adverse effects. Clinical applications. Personalized drug therapy. Genomic tests help predict how a patient will respond to specific medications, such as warfarin or clopidogrel. For example, patients with certain sick alleles may require an alternative antiplatelet therapy due to reduced metabolism of clopidogrel. Minimizing adverse drug reactions. Others. Genetic testing identifies patients at risk of others. For instance, the presence of certain HLA alleles like HTLB5701 is associated with severe reactions to abacavir. Dosing adjustments. Pharmacogenomics can guide drug dosing, such as adjusting the dose of thiopurines based on TPM-T enzyme activity. Challenges, cost and access. The widespread use of pharmacogenomic testing can be hindered by high costs and limited access to testing in certain healthcare settings. Clinical implementation. The integration of pharmacogenomic data into clinical practice requires healthcare providers to be knowledgeable about interpreting genetic test results and applying them to drug selection and dosing. Ethical and privacy concerns. Patient consent, privacy, and the use of genomic data for insurance or employment purposes are important ethical considerations. Relevant guidelines. Clinical Pharmacogenetics Implementation Consortium (CPIC) Guidelines for Drug-Gene Interactions. MS. Thompson, a 35-year-old woman, present with a history of multiple miscarriages and infertility. She is referred for genetic testing. A pathogenic variant in the MTHFR gene is identified. The patient is concerned about her ability to carry a pregnancy to term. What recommendations should be made to MS. Thompson regarding her genetic findings and what clinical interventions might help improve her chances of a successful pregnancy? Answer. The MTHFR gene variant, particularly the CT mutation, is associated with reduced enzyme activity, which may increase the risk of thrombotic events and potentially affect pregnancy outcomes, including recurrent miscarriage and preeclampsia. Recommendations. Genetic counseling. Explain the implications of the MTHFR variant, the associated risks, and the need for further testing or monitoring during pregnancy. Aspirin therapy. Low-dose aspirin may be recommended to reduce the risk of miscarriage and preeclampsia, especially in patients with this genetic variation. Folate supplementation. Ensure that the patient is taking a prenatal vitamin with L-methylfolate, as the MTHFR mutation can impair the conversion of folic acid into its active form. Blood clotting evaluation. Assess the patient for other thrombophilic mutations, such as factor V Leiden, to determine the need for anticoagulation therapy. Relevant guidelines is COG guidelines on thrombophilia testing in pregnancy. What are the implications of somatic mutations in cancer for targeted therapies, and how does tumor profiling aid in selecting appropriate treatment? Answer. Somatic mutations in cancer cells can be classified as driver mutations, which contribute to tumorigenesis, and passenger mutations, which are neutral. Somatic mutations provide crucial information for identifying specific molecular targets for therapy. Tumor profiling. Purpose. Tumor profiling involves analyzing the genetic alterations in a tumor's DNA, RNA, and proteins. This analysis can identify potential targets for precision therapies, driver mutations as therapeutic targets. For example, mutations in the EGFR gene in non-small cell lung cancer SLC, the tumor responsive to EGFR inhibitors like erlotinib. Similarly, mutations in the BRAF gene are targeted by vemurafenib in melanoma. Liquid biopsies can detect TNA-ECS, which reflect the genetic profile of the tumor and allow for monitoring of mutation status, treatment efficacy, and potential resistance mutations. Clinical application. Tumor profiling can help identify immune checkpoint inhibitors as a treatment option for tumors with microsatellite instability (ML) or PDL overexpression, as seen in some cancers such as colorectal cancer and melanoma. Challenges in tumor profiling. Not all mutations are actionable, and identifying the most relevant targets requires careful validation of the mutation's clinical significance. Cost and accessibility of comprehensive tumor profiling can be a limitation in some healthcare settings. Relevant guidelines. National Comprehensive Cancer Network (NCN) guidelines on molecular profiling and targeted therapies. Explain the concept of genome-wide association studies (GWAS) and how it contributes to our understanding of complex diseases. Provide an example of a disease identified through GWAS and the specific genetic variants involved. Answer. Genome-wide association studies (GWAS) are large-scale studies that aim to identify genetic variations across the genome that are associated with particular diseases or traits. GWAS examines the entire genome by comparing the frequency of genetic variants, usually single nucleotide polymorphisms or SNPs, in individuals with and without a disease. The idea is that certain genetic variants will be more common in individuals with the disease, pointing to regions of the genome that influence disease risk. How GWAS contributes to disease understanding, identification of risk variants. GWAS allows researchers to identify common genetic variants associated with diseases that were previously underappreciated or unknown. Understanding disease mechanisms. By discovering genes linked to disease, GWAS helps elucidate the biological mechanisms involved, often revealing pathways that could be targeted for treatment. Polygenic risk scores. GWAS findings can be used to construct polygenic risk scores (PRS) to estimate the genetic risk of an individual developing a disease. Example of disease identified via GWAS. Type 2 diabetes (TD). Several loci associated with TD have been identified, including variants in the TCFL gene. These variants affect insulin secretion and glucose metabolism. Limitations of GWAS. GWAS typically identifies common variants, and the effect sizes of these variants may be small, meaning they only explain part of the genetic risk. The studies often fail to account for the influence of rare variants, epigenetic factors, and gene-environment interactions. Relevant guidelines and resources. The GWAS Catalog, a comprehensive resource of GWAS findings.